welcome. Thank you for giving me this opportunity to talk in Sindh Medical College. I am Farah Mozaffar, and I'm class of 93 in Jinnah Medical University. I've been working in University of California in Irvine and working on dementia for last 15 years. Today, I'm really honored to have this opportunity to talk here. So the outline of my talk is I'm going to talk about a little bit of history of dementia, the definition, the different types of dementia, epidemiology, and the difference between normal aging and dementia, its diagnostic criteria, some pathology, and management. So this is the history of dementia. Alois Alzheimer was the first psychiatrist in Germany who described the patient in nursing home. The name of the patient was Auguste Deer, and she was 51 years of age in this picture, and he was closely following her behavior symptoms and the short-term memory problems. In 1907, he published his first publication about this case, and he followed till her death, and he described the plaques and the tangles, which is the pathology of Alzheimer's disease in this patient. And since then, the name of Alzheimer's disease after this German psychiatrist came up. So what is dementia? According to DSM-5 classification, dementia is a collective term for the group of neurocognitive disorders that is characterized by the decline in cognitive function, such as memory, orientation, language, executive function, judgment, calculations, and other domains. The word dementia comes from the Latin, which means mad or insane. It is important to note that dementia is a progressive disease. It impairs the ability of a person to carry out normal routine function, which he or she was used to do to live an independent life. And Alzheimer's disease is the most common type of dementia. So the most common question people ask us is, what's the difference between Alzheimer's disease and dementia? So dementia, as I said, is a syndrome, and it, as shows in the picture, is under the umbrella, all the disease of dementia came under into that. So Alzheimer's disease being the most common, and the few other which are listed here are Lewy body dementia, frontal temporal dementia, vascular dementia, some drug-related dementia, Parkinson's disease-related dementia, alcohol-related, and infections-related dementia. And I'm going to talk about a little bit of each type of dementia here. So Alzheimer's dementia is the most common, as I said, and it's a slow start, which we called, and the course of the disease is insidious, progressively downhill. So the short-term memory starts. Most common presentation of the patient is the short-term memory problems, and then some other domains. Vascular dementia is most common, happen after a stroke, and its onset is abrupt. Soon after a stroke, the patient starts having dementia symptoms. Lewy body dementia is another form of dementia, is in which the patient shows extrapyramidal symptoms. It starts with the visual hallucinations. The patient is seeing things which is not there. That could be an animal, or could be a human being, or could be an inanimate objects. And the course of this dementia is mainly fluctuations. So some days are the good days, and some days are the bad days. Insensitivity to the neuroleptic medication is common problem in this kind of dementia. And the next one is frontotemporal dementia. This kind of dementia happens in young elderly people from 40 to 60, as compared to Alzheimer's dementia, which usually happens 60 years of age and older. In frontotemporal dementia, the most common brain part which is involved is the frontal lobe and the temporal lobe. Behavior symptoms and the language is affected in this kind of dementia, is the main feature of this kind of dementia. Parkinson's disease dementia is the onset of the disease is by the Parkinson's disease, and later, maybe in 10 to 15 years, the symptoms of dementia appears later. So the early dementia is called mild cognitive impairment, and the main difference is the patient exhibits all kind of problems. It starts with a memory problem and other domains, for example, the problem with orientation, with language, with abstract thinking, with calculation. But the main difference is there is no loss of function. The person or the patient is able to carry his or her own functions independently in MCI, in mild cognitive impairment. So it's very important to discuss the prevalence of dementia all over the world. As we know, the people are living longer all over the world, and aging is the number one risk factor of getting dementia or Alzheimer's disease. It's all over the world. People are living longer. So in America right now, 95% of patients above the age of 65, uh, one in 9 people above the age of 65 have Alzheimer's disease. Right, 2015, 9.4 million had, and in 2030, 15.8. So it's almost like a double. And if we will see in Asia, 22.9 million in 2015, 38.5 million by 2030. So it's a global problem, and it's and we have to look at it. The most common question people ask, what is the difference between normal aging and possible indication of dementia? So I have listed a few of the problems. Like people commonly ask, oh, I forgot my keys. Is this dementia? So the difference in that, yes, when you lose your keys and you're trying to get it, you actually find your keys. And in dementia, it's really difficult to remember where the keys were placed, and eventually the patient cannot find where he placed his objects. For disorientation, for the normal aging, people do forget sometimes, oh, what day of the week is today, what is the date today, and why you entered the room, why you opened the refrigerator, but later it comes back to you. But in dementia, people have problem in orientation. They are lost in the year, in the month, what city, what place they are in, and it does not come back to them. Difficulty with daily livings. In normal aging, sometimes people do need assistance with an electronic device, but in dementia, it's hard to learn the new concept. For example, using the cell phone, for example, using the microwave, kind of a problem which we see commonly in dementia patients. The language is commonly affected. In normal aging, people do occasionally struggle to find the right word, but in dementia, it is difficult to complete sentences and follow directions or conversations. Usually, these patients, they forget the conversations, what they were talking about. Poor judgment is normal aging. Sometimes people make questionable or debatable decisions at time. But in dementia, it's unsure how to dress, how to give money, and how much money to write for donation, for example. Changes in mood and personality is a common problem as well. So how to diagnose dementia? So as I mentioned, impairment of the memory, which is to learn new or recall previously learned information, is the common problem and the most common symptom. And other domains, for example, the language, aphasia, I have put these medical terms, aphasia, apraxia, impaired ability to carry out motor activities, and agnosia is a failure to recognize or identify objects, impairment in executive function, which is a trouble or impairment in planning, organizing, sequencing, abstracting, For example, the patient has problem, for example, cooking, and to follow the multiple steps, in, and impairment in social and occupation function. However, it is very important to note that decline from the previous level of functioning and performing should be there, and the symptoms should not be explained by delirium or any other psychiatric or medical condition should not be there. So once if you have a patient coming with a memory problem or some other domains, so what you will do, how you will diagnose it. So the most common is to take a detailed history and to do the detailed clinical examination and detailed neurological examination. So in because a lot of dementia do have reversible cause, we can treat that, and the symptoms are reversible. It is very important to look and rule out these kind of dementias. Mini mental examination is a very common practice test people do all over the world. It's a 30 point question. The questions regarding the memory, first recall, second recall in 5 minutes, orientation, about similarities, about abstract thinking. It's to draw intersecting pentagons, to follow multiple step commands are all in the test. And Dr. Falstein was the first person who described this mini mental test in 1975, and it's used widely all over the world. Other neuropsychiatric tests are important to give it to the patients. For example, for the memory is California verbal learned test, in which the 8 or 9 words are given and the patients are tested how much they have learned, and then to recall in 10 minutes. Boston naming test, we show the objects of different things to the patient and we would like to name them. Digital span is another test of a working memory. So a lot of different tests are giving for different, to test different domains to the patient. Labs, we do routine test, we do thyroid, vitamin B12. ANA is another important test to check for syphilis, and HIV are another important to rule out other causes of dementia. However, American Academy of Neurology recommends to do MRI in these patients to look for the common hippocampal volume loss, brain atrophy with enlarged ventricles. And they found out that while carrying out these tests, the MRI, they found out 5% of these cases are treatable conditions. For example, subdural hematoma, normal pressure hydrocephalus, some brain tumor, and some vascular changes. Another test which people are doing or for mainly for the research purpose is PET, positron emission tomography, in which the radioisotope active material is given IV to the patient, and these isotope, they attach to the abnormal protein in the brain, for example amyloid and tau, and after a while they take MRI pictures of the brain, the imaging, and they see how much proteins are attached to these or how much abnormal proteins are there. And also to check glucose, FDG is a glucose measuring test through PET imaging. The genetic marker ApoE4 is also done but is not recommended. There are the homozygous and the heterozygous. If a patient is heterozygous, for example, one allele of ApoE4 is there, there is a 2% increase of risk of Alzheimer's disease. And if a patient is homozygous with 2 alleles, the 15% fold increase in risk of Alzheimer's disease. Some other rare form of dementia is the familial forms, in which the patient or the whole family, one generation after another, develops dementia at the age of 40 or 50. So the chromosome testing is important in these patients. This is a picture here showing MRI of the patient. So this is a prodromal AD, which is just the symptoms have started. So if we are looking here, the brain is almost full, the cerebrum, we are looking at the ventricles here, and this is the hippocampal area, and we're looking at the shape here, and we advance with, if we are comparing with advanced Alzheimer's disease, so look at the loss of the brain tissues here, so much spaces are there, there's enlarged ventricles, and compare the hippocampal volume is here full, and here is a loss of hippocampus. And these are the main pathognomic features of Alzheimer's disease. This is the naked eye presentation of the brain. So on the left is the normal looking brain, and here we are again looking at the hippocampus with the ventricles and the cerebrum, and on the right is a severe demented Alzheimer's brain, and the same picture shows a normal and Alzheimer's brain here. So what happens in the brain? What is the pathology? So we all know that the brain is made of brain cells. These are the neurons. 100 billions of neurons are present in the cells, and they are the structure of the neuron is they have a cell body, and they are connected to the axons by the intersynaptic tissues. Neurons connected at synapses where neurotransmitters pass signals between the cells, and these transfer of electrical and chemical impulse creates memories, thoughts, and feelings. So what happens in Alzheimer's disease? Here, if we look at the pathology of these brain cells, so we see from this normal brain, a naturally occurring protein, which is called beta amyloid. They clump together, and they call the clumps that is called plaques. And these are extracellular inside the brain tissue. And we also see the most pathognomic is to tangles. These are also the twisted strands of proteins, and they are intracellular, and they are deposited inside the neurons. And when these abnormal proteins are deposited inside and outside the brain cells, what do they do? Tangles may disrupt the neuron's transport system, which moves nutrients, cell parts, and other supplies. Plaques, which is the amyloid, may block cell-to-cell signaling at synapses, and they also activate immune system cells, which trigger inflammation. So it is now, by the research of dementia and Alzheimer's disease, it's thought that the early or the mild effect of learning and memory problem changes inside the brain that begins 20 years before the starting of the symptoms. So in the middle or moderate dementia, memory, thinking, and planning, with the impaired, these kind of patients, they live up to 10 years. And late on, and the late in the disease progress, when the patient is involved with language and understanding, they may have these kind of symptoms that last for 1 to 5 years. So that totally comes like one of the dementia sign and symptoms may present in the patient for maybe 30 to 40 years inside the brain. So when these patients come to you, what do you do? So the diagnostic and prognostic counseling is important. So as we know, there is no cure for dementia, no cure for Alzheimer's disease. So the treatment of behavior symptoms and is very important. If a patient has agitation or disruptive behavior, neuroleptic agents are most commonly used in this kind. If the patient has depressive symptoms, it should be treated by antidepressant agents. Social gathering, caregiving, nursing, and the routine physician visits are very important in taking care of these patients. And if we look at the medications, FDA has approved 4 medications so far, and these medications, 2 different classes. 3 of them are acetylcholine inhibitors, that they disrupt the release of acetylcholine at the synapses. However, the most common is used donepezil, rivastigmine, galantamine. The most common problems in taking these medications are the side effects, the GI side effects, and the patients cannot tolerate these, and that's why it's very common practice to start with a very low dose and to see how the patients are tolerating these medications and to increase it slowly. The another class of medication is memantine, that is NMDA receptor antagonist, that is used in moderate to severe kind of Alzheimer's disease or dementia. The dose is usually 10 to 20 milligram. However, hallucinations and confusion are the most common side effects of these medications. A lot of studies have shown that they may slow down the progression of disease little bit during the course of the disease, but the end point is all the same even after taking the medication, because we all know that dementia is a neurodegenerative disease and it progresses over the time. A lot of clinical trials are going on at this point, and hoping for the future, for the best to come out something. So with this, I really thank everyone who is involved in taking and making this video happen. I really appreciate all of your effort, and I hope it helps in the lectures and in the examination. If you have any questions, you can reach me at my email is fmozaffar@uci.edu. I can spell as FMOZAFFA@uci.edu. I'll be happy to take any questions from all of you, and thank you again.